Hello everyone, today we are going to learn about this psoriasis. So let us see in detail about this psoriasis today. So let us see first what is psoriasis. So it is a common chronic skin disease. Chronic means something happening for a long duration of time. So this psoriasis will be present for a long duration of time. So it is characterized by increased proliferation activity. So here the increased proliferation activity of cutaneous keratinocytes is seen, that is called as turnover rate of cutaneous keratinocytes. So the normal turnover rate of cutaneous keratinocytes are 23 days, while when we talk about psoriasis it becomes 3 to 5 days, that is it reduced from 23 days to 3 to 5 days because there is this cutaneous keratinocytic layer is get away or get destructed very easily. Now let us see what is the etiopathogenesis of this proliferation of cutaneous keratinocytes. So what happened? Activated T lymphocyte leading to abnormal production of cytokines, adhesion molecules, chemotactic polypeptides and growth factors. So this activated T lymphocyte which is get activated because of the autoimmune mechanism. So you can see because of this T lymphocyte will going to produce all this abnormality in these factors and which will lead to this proliferation of cutaneous keratinocytes. Now let us see what all are the etiology of psoriasis. So it can be autoimmune reason, it can be because of genetic reason, it can be because of unknown idiopathic reasons, that is environmental factors, etc. So now let us see what are the precipitating factors. So this psoriasis will be more seen during the mental anxiety state and during the stressful conditions. And this psoriasis will become severe in winter while it will be less severe during the summer season. So these are the different factors. Now let us see the clinical feature of this psoriasis. So age usually affected is 2nd to 3rd decade of life. Gender usually there is female predilection. So female will more involved than that of the male. Lesion usually involved on the skin, nails and the oral mucous membrane. Now let us see skin lesions. So how the skin lesion will going to be look. So it is in the form of usually papules. So what is papule? Papule is solid raised lesion which is less than 5 mm in diameter. So how papules are in this case of skin lesion? So papules are usually small, sharply delineated, dry, covered by delicate silver scales, and this delicate silver scale which is it covered by, it resembles the thin layers of mica. So it is important to remember it resembles the thin layer of mica. There are different types of skin psoriasis is seen. So you can see in first picture. So the first type is vulgar psoriasis. So you can see this is the typical picture of it. Second is psoriatic erythroedema. So you can see here this is the typical picture. Third is gutted psoriasis. So you can see here. And the fourth is inverse psoriasis. And lastly pustular psoriasis. So these all are the different type of skin psoriasis. So now let us see what is this Auspitz signs. So what is this Auspitz sign? If the deep scaled are removed, so if we remove the deep scale from the psoriasis surface, so they reveal tiny pinpoint bleeding. So you can see if this psoriasis surface is removed by some instrument, it will lead to formation of this pinpoint tiny bleeding points. So this is the Auspitz signs. It is very important MCQ question where the Auspitz signs is seen. So you have to remember Auspitz sign is seen in psoriasis. So you can see this is the typical clinical picture how this skin lesion of psoriasis will going to look. So now next moving forward to what are the different oral lesions seen in this psoriasis. So the oral lesion can be occur on different forms. So there are usually 5 different forms. So let us see each of it one by one. So you can see the first form is well defined yellowish white lesion. So they will be usually round or oval in shape, interdependent of cutaneous psoriasis. So they usually occur along the cutaneous psoriasis. Now let us see the second form, that is white lacy or elevated lesion is seen. It is usually occur on tongue or the buccal mucosa associated with skin lesions as well. So here you can see here is a white lacy elevated lesion can be seen over the tongue, and also you can see here the lesion is also involving over the buccal mucosa. So this is the second form of this psoriasis. So now third form is erythema or redness of oral mucosal surface is seen. It is also associated with skin psoriasis. So here you can appreciate the redness or erythema of this oral mucous membrane. So this is a third form of oral psoriasis. Now the fourth form is the geographic tongue, also called as erythema migrans, benign migratory glossitis, or the wandering rashes of the tongue. So it is frequently associated with skin psoriasis. So here you can appreciate all these white patches. These all are wandering rashes of the tongue, that is our geographic tongue or the erythema migrans. Or you can also appreciate one more thing you can see in this center, that is cleft tongue is also present. That is the partial cleft is also present. So this is the fourth form of oral psoriasis. Now let us see histopathological features. So here prominent tortuous blood vessels is seen, which is reaches high into the connective tissue papilla. So here the tortuous dilated blood vessel is seen. Mild lymphocyte or histiocyte infiltration is usually seen, and the most important feature, that is intraepithelial abscess, is seen. This intraepithelial abscess is known as Monro's abscess. So it is a MCQ question here again. The question can ask where the Monro's abscess or the intraepithelial abscess is seen. So the answer is psoriasis. So this abscess is nothing but collection of neutrophils within the parakeratin layer. So here within the parakeratin layer there will be accumulation or collection of neutrophils is seen. So that is Monro's abscess. So now let us see other histopathological features. So here parakeratinosis is seen. So here the retention of nuclei is seen within the horny layer, that is spinous layer, due to rapid turnover rate. Also diminished granular layer is seen. Elongated and the clubbing of rete-ridges is seen. So the rete-ridges will going to be elongated and clubbing of rete-ridges is seen, that is rete-ridges will be like elongated and clubbing, that is bulging of the rete-ridges is seen. So now let us see in this histological picture. You can see here hyperkeratosis. You can see these all things are hyperkeratosis. You can see thin suprapapillary dermal palate is seen. So you can see this is the elongated rete-ridges, also called as club shaped rete-ridges, is seen in psoriasis. So this can again a MCQ question, that where club shaped rete-ridges is seen. So it is in psoriasis. And Monro's abscess is seen here. You can see this is the Monro's abscess. So it is again a MCQ question. And dilated blood vessel you can appreciate with inflammatory infiltrate within them is seen here. And you can see there is spongiform pustule is seen within the spinous or granular layer. So there will be diminished granular layer cell is seen. Here also you can see parakeratosis is seen. So you can see these all are the different histological features of psoriasis you can see in this histological picture. Now let us see what is treatment for this psoriasis. So usually there is no proper cure of it, but our aim should be to induce remission and to make it more tolerable. So for that we usually use a topical treatment by using the coal tar. So this coal tar was used for psoriasis in ancient times. Nowadays it is not at all used. Others can be calcipotriol and the corticosteroids. So nowadays the most important treatment for psoriasis is topical application of this steroid over the lesion. Spontaneous remission is usually seen in 50% of the cases usually, and if the oral lesion is involved and it is because of the smoking and all, so the person should quit the smoking for the proper cure. And also there is light therapy is also available. So these all are the different therapies. So today we have seen psoriasis and what are the different clinical features of psoriasis, what is the skin lesions of psoriasis, what is the Auspitz signs, very important, and what is the oral lesion involved in it, what is the treatment, etc.